Thank you everyone today for listening, and I'm going to talk about auditory neuropathy and Riboflavin Transporter Deficiency. As noted earlier, I am the Science Director of the Cure RTD Foundation, and I've been involved with RTD field for close to 4 years. As John mentioned, RTD I find is a very important one for audiologists to know about. Without proper treatment, RTD is a devastating and life-shortening neurodegenerative disorder that occurs most often in children and young adults. So I have two major goals from this presentation. Given that hearing loss is the first sign of RTD in approximately 30% of patients, and almost all patients with RTD will develop severe hearing impairments over the course of the disorder, I view those in the clinically audiology field as one of the first line of defenses in getting these patients life-saving treatment. My goal to those listening is they can recognize the early symptoms of RTD, existing in early diagnosis, and also for patients that have progressed for many years that they recognize what the disorder looks like now, because it looks like the large majority of cases have yet to be diagnosed. Do not make the assumption that other physicians looking at these individuals know about RTD, and as Maggie noted, it took 10 years for the diagnosis of her patient, who is now on treatment and thankfully stabilized. My other goal on this presentation is to provide you a background on what we know about hearing loss with RTD and how to best management, including cochlear implants. So I'm betting the majority of you prior to Maggie's introduction have not heard of Riboflavin Transporter Deficiency, or RTD. I'll give you a quick background to tell you why that's the case. So Brown-Vialetto-Van Leare Syndrome, or BVVL, was first reported in 1894 as an infantile form of ALS, almost always associated with hearing loss. This was considered an extremely rare disorder, and before 2010, less than 75 cases of BVVL had been reported in the literature. The cases reported in the literature had a wide variation, with some dying within a year of onset of the symptoms and others surviving for decades. There was no known cause of the disorder or no effective treatment. Just recently in 2008, between 2008 and 2010, the SLC 52A1, A2, and A3 genes were identified for the first time as riboflavin transporters in humans. These transporters bring vitamin B2 that we ingest into cells throughout the body. Riboflavin is an indispensable micronutrient and cannot be synthesized in humans, so we must ingest it on a regular basis. It's essential in various lipid, carbohydrate, and amino acid metabolism, and also in many important cellular pathways. Shortly after the gene was discovered, in 2010, the SLC52A3 gene was found to actually cause BVVL, and when patients were given high-dose riboflavin, they were found to either stabilize or some showed clinical improvement. And more recently, in 2012, the SLC52A2 gene was found to cause BVVL also, and patients also responded to riboflavin. As a result of this discovery, the name of the disorder is being changed, so patients that have the SLC52A2 mutations are now referred to as having Riboflavin Transporter Deficiency Type 2, or RTD Type 2, and those with the A3 mutations are considered to have RTD Type 3. So RTD is an autosomal recessive disorder, so requiring a mutation to be inherited from each parent. So if each parent has the carrier mutation, they have a 25% chance of having a child with RTD. This is also important because if treatment can be started earlier, it's possible that all progression can be avoided. So if you can identify it in an individual, their siblings can be tested. From a neurological standpoint, it's considered a progressive sensorineural and cranial neuropathy. Again, the reason I'm talking with you today is 95% of the cases will have hearing loss, and 30% will have it early. So far from the cases we've seen, about 80% or more present between 3 months and 14 years of age. However, we've seen many cases present in their 20s and 30s, and as we learn more about the disorder, it's possible it can present at any age. The treatment is very high-dose riboflavin taken 2 to 4 times a day for life, with many patients taking other supplementations. So I'd like to give first a broad overview of RTD. Now, it does look very different between individual patients depending on the age of onset and the type of RTD, but as a general overview, approximately 95% have progressive hearing loss. Approximately 80% have some sort of progressive proximal and distal muscle weakness. Approximately 75% will have some sort of bulbar involvement because of issues with the cranial nerves. This normally shows up as feeding and speech difficulties, but I'll cover off some other items that are seen more commonly. Approximately 75% will have progressive respiratory problems that are a result of either diaphragm paralysis, accessory muscle weaknesses, or sometimes vocal cord paralysis. About 50% will have vision loss, which sometimes can be very severe, and 50% will have sensory gait ataxia, which will present as a wide base unbalanced walking. As a result of the weakness and balance issues, the large majority of cases do end up using a wheelchair eventually if left untreated. What is very important on this disorder is cognition remains absolutely normal in all cases. One of the reasons why this disorder has flown under the radar is because we don't have any good biochemical abnormality markers. In approximately 50% of cases, there is no abnormalities noted. So therefore, it's very important that people recognize the clinical symptoms of this disorder and then confirm it through genetic testing. So there's very little written in the audiology literature on RTD. In 2010, Cincinnati reported on 2 siblings who presented at 9 and 13 years old with progressive hearing loss and several other classic BVVL symptoms. They received cochlear implants at age 41 and 45 after 20 years of profound deafness with no speech perception. One case was considered a moderate success at 6-month follow-up, but the other case still had no speech perception at 4-year follow-up. The family from this paper was very recently diagnosed with RTD type 2, so I can now consider this a genetically confirmed case. I'm actually in contact with a female from this paper. She's now 10 years post-implant, and she has reported continued improvement in speech recognition and is extremely happy with her CI decision. Sadly, her brother passed away shortly after this paper was published. In 2014, Salamano reported on a patient that had rapid hearing loss at 20 years old and classic BVVL symptoms, but no genetic diagnosis. They did an extensive audiology workup at 30 years old. Based on functional MRI testing, they concluded that the central audiology pathways appeared intact and thought the patient would be a good candidate for CI. Finally, more recently in 2016, Mano Menez and his colleagues in Australia presented the first comprehensive report on hearing loss associated with RTD type 2. Mano provided data on 7 children across 4 families and showed that hearing loss was consistent with an Auditory Neuropathy pattern, or ANSD. In addition, he demonstrated the successful use of a cochlear implant for the treatment of hearing loss from RTD in a single patient. So the audiology testing in both RTD type 2 and type 3 leads to a pattern of audioneuropathy in all patients. This includes the ABR being either absent or abnormal with present cochlear microphonics. OEEs are often present at the start, but we found they most often disappear over time, and acoustic reflexes are absent. A large number of these patients have had MRIs many times and also CT scans, and there's no evidence of any damage to the audiology system, and the cranial nerve or the auditory nerve looks completely fine on all of these scans. So the hearing loss in RTD can occur at any age from early infancy to over 25 years. The pure tone threshold can range from mild to a profound loss. The hearing loss can progress to profound loss in just a matter of months or be slowly progressive over decades. So far in my experience, what I've found is about 80% of cases, especially those that present under 10 years old, are relying on lip reading within 2 to 3 years of onset of hearing loss. The hearing loss is bilateral, often asymmetric, and very similar to all other ANSD cases, there's a disproportionately poor speech recognition ability for the degree of hearing loss, even with properly fitted hearing aids. They have difficulty hearing in noisy situations, and the hearing fluctuates from day to day or even intraday. Patients with poor speech recognition with RTD have reported limited or no benefit from hearing aids. Looking at all cases to date, I'm only aware of a couple of cases that have had properly fitted hearing aids that have given them any benefit that they still wear on a regular basis. So we don't know the site yet of the auditory lesion in RTD. However, prior to 2010, in some genetically unclassified BVVL cases, there are several postmortem studies, and these show damage to both the auditory nerve and cochlear nuclei. However, we do not see any evidence of pathological changes in the higher auditory pathways, which makes many of these patients good candidates for CIs. Most of the literature on RTD notes hearing loss as the presenting symptom. This does not actually appear to be the case, and instead the onset of hearing loss is dependent on both the type of RTD and the age of presentation, and also the specific genetic mutation. As noted in this table, about 50% of RTD type 3 patients over the age of 5 do present with hearing loss as a first symptom. There is often a gap of 1 to 10 years between the onset of hearing loss and the onset of other symptoms. This is why it's so important I'm talking to you today, because you may treat these patients and then see these symptoms develop over time. In this subset group, the RTD patients over 5 years old, an additional 30% will initially present with a combination of hearing loss and some other symptom. Only 20% of these cases will show some other symptom without hearing loss, which may occur anywhere from 1 to 10 years after the onset of symptoms. Few RTD type 3 cases under the age of 3 present with hearing loss alone as the only symptom. Approximately 60% of these cases will present with hearing loss combined with some other symptom at the same time. So you may be called in to see these patients and they may already have symptoms of RTD. The other 40% of these cases do not have hearing loss show up for up to a year after the onset of the first symptom. RTD type 2 also rarely has hearing loss noted as the first symptom alone. In approximately 30% of the RTD2 cases, you'll often note hearing loss in combination with either sensory gait ataxia and or vision loss as a presenting symptom. I think Maggie presented very well on a case of hers who did have RTD type 2, and she had this combination progress over time. So we see in all of these cases is they normally have normal language development until the onset of the disorder. I'm often asked, can newborn screening potentially catch these cases very early? Well, so far I'm aware of about a dozen cases that have had either newborn ABR screenings or screenings before the onset of symptoms. All of these ABRs look normal. The only case I'm aware of was a case presented in the Menez paper where a child with RTD type 2 had hearing loss at birth. However, they had congenital hearing loss that was not related to RTD run in their family, so it's possible that this child's hearing loss was a result of a different disorder. This graph shows the dark blue bars is the age of onset of first symptoms, and the light blue bars is the age of hearing loss. What you will note is cases 1 to 7 actually never had documented hearing loss. In the literature in the past, patients that had BVVL symptoms but did not have hearing loss were referred to having Phasio-Lond. It remains unclear if patients survive long enough if hearing loss is seen in every patient. In these cases, patients 1 to 3 died under 2 years old, potentially before the onset of hearing loss. In cases 4 to 7, were actually recognized as having RTD and started on riboflavin treatment potentially before the onset of hearing loss. The last subset I'd like to talk about is RTD type 2. It's caused by the SLC52A2 mutation. So far, all the cases that we've seen present somewhere between the ages of 3 months and 14 years of age. Again, this graph, the blue bars represent the age of presentation, and the light blue bars present the age of hearing loss. What you will immediately note is almost all cases with RTD type 2 present between 1 and 3 years old. In this subset of patients, only 10% had hearing loss as the presenting symptom. Interestingly enough, those patients that presented with early hearing loss also tended to be the most mild cases and presented over 5 to 6 years of age. So these are good ones to have on your radar for ones that present only with hearing loss and then start to develop gait ataxia, vision loss, etc. In 30% of these cases, they will present with hearing loss in combination normally with either gait ataxia or vision loss. The other 60% will actually have symptoms before hearing loss, with the hearing loss occurring anywhere from 3 months to 6 years after the initial presentation. The presentation of RTD type 2 looks very different from the early presentation of RTD type 3. Again, the initial symptoms and progression can be very different between patients and even between siblings carrying the identical SLC52A2 genetic mutations. The most common presenting symptoms seen in these patients, in about 65% of them, is sensory gait ataxia. What you'll notice is a very wide-based, unbalanced walk. The motor planning is actually very decent in these patients, and because they don't have cerebellar involvement. Cases presenting under 1 year of age may never walk or need someone to assist them to walk. As the disorder progresses untreated, most patients will require wheelchairs because of the ataxia, but their legs actually remain strong. These patients will normally have absent reflexes in their lower and upper bodies. So approximately 25% of cases will also present with nystagmus or vision loss. This is often seen in conjunction with sensory gait ataxia. 25% will also present with muscle weakness. However, unlike the type 3, this muscle weakness is predominantly in the upper limbs and axial muscles, with their legs remaining very strong. The weakness in many cases can be rapidly progressive, with some patients going from normal arm strength to flaccid paralysis in their arms in under 6 months. So once again, this is why recognizing these symptoms and getting treatment early is so important. Although respiratory issues will develop over time in the majority of patients, it is often not the presenting symptom in RTD, and there's often many years before respiratory symptoms develop. Other early symptoms we see more rarely in cases include anemia, ptosis, some feeding difficulties, and blue spells. So untreated, the RTD type 2 cases over a long enough period almost all develop a combination of hearing loss, muscle weakness, vision loss, and gait ataxia. So these 4 things combined are a way you can recognize later stage cases that you may be dealing with now. In the majority of cases, hearing loss is rapidly progressive, and patients are normally reliant on lip reading within 2 to 3 years from the first sign of hearing loss. RTD type 2 is one of the very few neurological disorders that results in a severe upper limb and axial muscle weakness while the legs remain strong. Weakness is often noted in the hands first and progress to the point where patients cannot lift their arms or hold up their heads. So once again, if you see this type of progression of the upper limbs in a patient and their legs remaining strong, your spidey sense should be going off, as I joke. Vision loss in these patients progress over many years or can be rapidly progressive, leading to legal blindness in under a few months. In young children, nystagmus is often the first sign of optic nerve atrophy, even before vision loss occurs. Most patients will eventually develop respiratory issues requiring either the use of nighttime BiPAP or, in more advanced cases, a need for full-time ventilation. Again, this is in untreated patients. However, respiratory symptoms, as I mentioned, are not always present at the onset, and in fact, I'm aware of several adult cases with relatively severe other symptoms that don't appear to have any respiratory issues. The majority of cases do develop speech and feeding difficulties secondary to bulbar dysfunction, which is normally the result of tongue weakness, and you often see tongue fasciculations. It's also common in these patients that they will require spinal fusion for scoliosis as a result of axial weakness, getting this surgery usually sometimes between 7 and 14 years of age. Other features seen in these cases very early can be facial weakness, which may or may not be symmetric, ptosis, sometimes they have strabismus. I would say about 25% of cases have some sort of anemia, some severe. They often have GI distress and sensory loss. So from the audiology side, I am personally aware of 23 cases that have received cochlear implants anytime that have had them between 6 months and 13 years of age. I'm pleased to say that although the results are variable, the large majority have received very significant benefit from their CIs and are very pleased with the decision to move forward with getting their CI. The few cases that have had less than optimal outcomes include those that have had very long-term profound deafness, similar to the case I talked about earlier of the 45-year-old who had been deaf for over 20 years, and also those that have had extended periods of prelingual deafness. Now, most of these children actually develop speech, so you have to take that in consideration. They often lose their hearing after developing some of those speech pathways. However, even in these cases with less than optimal outcomes, I cannot discount how much sound awareness can add to the quality of life when dealing with multiple disabilities. So I'd like to finish off here with going over some case examples of what we've seen on the audiology side. So case example 1 was presented in the Menez paper. So this is a 9-year-old girl who I would consider to have a mild form of RTD type 2. So from 3 years old, she had a sensory gait ataxia with a wide base unbalanced walk. Between 9 and 10 years old, she had a rapid progression of neurological symptoms, one of them being a rapid loss in hearing and also speech perception. Luckily, within 1 year of the onset of the hearing loss, RTD was diagnosed and she was started on riboflavin treatment. The left graph shows how her audiograms improved across the board, but unfortunately, even with the improvement in her audiograms, she had little improvement in speech perception. She received a unilateral cochlear implant at age 12. I'm pleased to say that this implant was a great success, and at follow-up at 6 months, 12 months, and I know this patient over 2 years later, she is in mainstream school and she's had excellent speech perception across the board. So case 2 is an RTD type 3 patient. So this patient had a classic presentation. So she had progressive hearing loss and vocal cord paralysis at 18 months old that was relatively minor that she went into an audiologist and a doctor for. Then at 22 months, she had a very rapid decline that resulted in a tracheotomy, very severe muscle weakness to the point that she had full paralysis and profound deafness. Once again, luckily, they recognized the symptoms of RTD, and within 6 months of presentation, she was started on riboflavin treatment. Fast forward to 7 years, and this child is doing well, but she was a fluent signer, but with no spoken language or speech perception, even with extensive trials of hearing aids and speech therapy. At 7 years, the decision was made to give her a cochlear implant. So you can see her audiogram here right before the implant, and in the one ear she had across the board severe, almost profound loss. The other ear, which I see commonly, is the audiogram is all over the board with moderate to profound loss. So 8 months post-implant, I'm happy to say this child is hearing at 35 decibels across the board, and she's already added a dozen spoken languages. This child is extremely happy to have her CI, wears it every waking moment, and the family has been very happy with their decision. The last case I'd like to go over is actually my daughter Julia. So as noted earlier, between 3 months and 2 years of age, she had the classic symptoms of RTD type 2. She had completely normal language development, and at 2 years old, she was stringing together long sentences. After severe respiratory illness, we saw the first signs of hearing loss, and she started saying "what" a lot. Within 6 months, she had progressed to a profound loss and had largely stopped talking. At 2.5 years old, we started the riboflavin treatment. So the first audiogram you will see is after 4 months of riboflavin treatment, and you will notice she had profound to severe loss in both ears across all frequencies. Fast forward 1.5 years on treatment, and you will see a very significant improvement in her hearing. We actually were in the booth about every 5 weeks, and we saw this gradual improvement occur over the 1.5 years. However, even with over a year trial with properly set hearing aids and extensive speech therapy, we still only had a 10 to 20% accuracy on closed word set. So she was not progressing on her language. At that point, the decision was made to give her a unilateral cochlear implant. So fast forward now, so she's now been on treatment for 3.5 years and had her cochlear implant for almost 2 years. I'm very happy to say that the cochlear implant was the correct decision. Her language has been progressing rapidly, and she has close to 100% accuracy on closed word set. I also know that the CI was a proper decision because in her non-implanted ear, what we've seen is the hearing has largely stayed stable, but we've seen no increase in her speech perception and is still approximately 10 or 20% in the non-implanted ear. So, can riboflavin prevent long-term hearing loss? The longest that I know of any case on riboflavin is 9 years, and the results so far are encouraging, and those children have not developed hearing loss. So far in other cases, hearing loss appears to be either stabilized or improved in patients on aggressive treatment. In addition, pre-symptomatic siblings of RTD patients started on riboflavin early have shown no signs of hearing loss. Once again, I think this is why it's so important to find these patients, because each sibling has a 25% chance of having the disorder, and treatment can be started before any neurological declines happen. So my takeaway message here is that the emergence of clinical signs of RTD need to be investigated immediately. Given that the damage from RTD is irreversible and riboflavin supplementation is life-saving, riboflavin therapy should start the second that you believe RTD is in the diagnosis, and do not wait for the results of genetic testing. Cochlear implants are a viable treatment strategy in RTD patients who are not responding to hearing aids. I am in complete agreement with the Menez 2016 paper, and what they suggested was in new patients that are just starting treatment that riboflavin is given for 1 year to see how much improvement happens in the audiology side and with hearing aid trial. If after 1 year there's still poor speech, then a cochlear implant should be considered. I will leave it with that riboflavin is a treatment for RTD but not a cure. It remains unclear if riboflavin treatment in its current form will be effective in preventing symptoms for life, or whether it just may delay some of these symptoms over the long term. So more research is necessary to understand these mechanisms and also to optimize treatment. And that concludes my presentation. Thank you so much for listening.
All right, thank you, Keith. So we hope everybody found this presentation to be helpful. We would like to open up for questions if anybody has anything for any of the presenters. Okay, we have one question. This is either for Dr. Massey or Dr. Greenwald. Let me see if I can access the whole. Carolyn, I don't know. I can't see the whole question. Oh, there it is. The benefits of riboflavin seem obvious for RTD.
I can answer
general
that
population,
one.
Is there a risk to riboflavin toxicity taken in such high dosages? Keith?
I can answer that one. So thankfully, riboflavin, yeah, absolutely. Can you hear me? Yes, sorry, can you hear me still? Okay, great. So yes, so the good news is riboflavin taken even in very, very high doses, and these patients take up to 1,000 times the daily RDA for riboflavin, does not appear to have any toxicity. And in fact, for their other disorders that have been taking high-dose riboflavin for over 20 years, and it's actually used for migraines even. They take, some patients take upwards of 400 milligrams twice a day for migraines. So the reason why it doesn't have toxicity is when taken orally, the body will only absorb a small amount of the riboflavin, and riboflavin that is absorbed is expelled rapidly if it's not utilized.
Are there any other questions? So in the meantime, we will ask some questions to each other, and hopefully we'll address some of the questions that people may have. So, John, did you have a question to start?
So Maggie, one of the things I'd like to note is what you didn't mention in your presentation, but I'm obviously well aware of, is that you currently have are seeing 4 cases of RTD. So when people see some sort of frequency like 1 in a million, they often believe they'll never see a case in their life. But as I've made the rounds and talked to many audiologists, what I've found is many of them have seen 1 or more cases in their career that they never recognized had BVVL or RTD. So I'd like to ask you, so these patients now have had CIs and on treatment, and just what your overall impression is.
That's a great question, Keith. And, you know, John and I were talking earlier about how the 1 in a million statistic is so hard because I do have 4 that live pretty close to the Cincinnati area and are receiving treatment here. And I've had communication with a few other families with the diagnosis as well over the past couple of years. And it does seem, at least from my perspective, that the patients really do benefit from the cochlear implants. You know, looking at the outcome measures that we often test with patients with implants, we can't always get the same open set recognition scores or the same hearing and noise benefits that we would, but it does seem, at least from the qualitative approach when I ask the patients, are you happy with your implant? I have a unanimous from my small group that it is yes, that they feel more connected and that they really can perceive a benefit. And they do understand and hear with their implants, just not necessarily the same way as we see with other patients on some of the testing that we usually would do.
Thanks, Maggie. And I think it's worth noting that the patients that you have are all older patients where I know 2 of the patients are in their 20s that received implants after living with the disorder for over 20 years. And in my experience, what I've seen is the younger cases that are implanted, those implanted at 3, 4, 5, 6, seem to do extremely well. So I think it's worth noting in those cases that are diagnosed even in their 20s or 30s, that cochlear implant still needs to be considered for those patients.
Absolutely. And I did have a question that I think the 3 of us could all discuss from our perspective, and that is, at what age do you really feel comfortable moving towards a cochlear implant for these patients? So knowing that there's a chance of hearing improving and things like that, how long after treatment, how long after diagnosis should we really take into consideration the cochlear implant option, knowing that we need to provide as good of access as early as we can?
So I think that's an excellent question. I covered that off a little bit, but basically what we've seen so far is that any hearing improvement happens within the first year. So I've now seen many, many cases that have been on treatment for 4 or 5 years, and if they're going to see an improvement in hearing, it's going to be generally in that first year. So I wouldn't delay any more than that first year waiting for hearing to improve.
John, do you
Sorry, hopefully that answers your question.
Yeah, and I would agree with that too. I mean, I know for the young children, it's something that we discuss over and over of getting them as quality access to sound as quickly as we can, but it's important for this population that we do make sure that we're doing what's right for them with their unique circumstances. So I think we have another question. So when referring to a genetic counselor, what tests should be recommended and what specific panel or battery of tests or question mark?
So I'll start off and then I'll let John finish. So unfortunately, the SLC52A2 and A3 gene has yet to be added to the general audiology panel that's given. So I believe usually covers about 150 genes. So I'll continue to work towards hopefully having these genes added. So in the case of RTD, they actually will need to they will not get picked up by the standard audiology panel at this time, but there are many places that offer testing specifically for the RTD gene. It's also now in the gait ataxia panel in the U.S. And getting added to the vision panel.
Is my microphone working now? Excellent. Yeah, so from the general sensorineural hearing loss panel, we are actually now going to be incorporating that into our OtoSeq panel here at Cincinnati Children's. And even though it's relatively uncommon, and if you just look at the Cincinnati experience, we'd say 4 cases out of about 1.5 million. So that's still about 1 in 300,000. That's exponentially more common than 1 in a million, and of course the more we look, the more we find. So we will be including that. We'll have to just see if other testing centers will start including that, but because there's such a important reason for diagnosis, aka treatment, then I think you're going to start seeing that pop up on most routine genetic panels. Now, it's interesting, this condition may be of extreme help to those of us who are molecular geneticists, and the reason is the insurance companies now are balking on paying for genetic testing for hearing loss. And so this condition actually is going to be the beginning of hopefully many things that we determine in which understanding the genetic cause of hearing is going to be really important. So, oh yeah, well, I've got our microphone that's working here. One question I did have, and initially for Keith and maybe for Maggie, is with treatment with riboflavin, is there any data so far that shows actual discrimination or speech understanding is actually improved besides just the tones? And so first Keith and then Maggie.
Yeah, so unfortunately this the speech perception does get better, and in fact what I've seen is it's not being published, but I've seen enough cases, even with adult cases. So I'll use a good example of a child, 14 years old with A3, first started having troubles hearing in class, basically went 5 years before basically having other symptoms, rapidly progressed in their early 20s, resulting in a trach, weakness, and then started on riboflavin treatment. Speaking with these individuals, few individuals like this, even in their mid-20s, what they've been able to tell me is all of a sudden people that they couldn't hear before, they can now understand. So I think just anecdotally, based on talking with many of these cases that still have decent enough hearing that they can function, they do have increased speech perception. Now, in the more severe cases, such as the one I presented with my daughter Julia, we see the audiograms get significantly better, but often do not see their speech perception increase very much. So I'm kind of taking both approaches. So yes, in some we do see significant improvements, in others we just see the audiograms improve without significant improvement in the speech perception.
And this is Maggie. I'll chime in as well. As far as the patients I see, I only see one patient who had the cochlear implant and then the riboflavin after. The other ones had started the riboflavin treatment prior to the implant, but all of the patients do have some benefits with their implant, and I don't know if I would be able to tease out what was impacted by the riboflavin versus the implant, and how they would have done without that treatment, if that makes sense.
one of the things we'll be wrapping up on time, which I never got a chance to present, but what I think is important for people listening is I presented some very severe looking cases, but I think as time goes on, we're probably going to find a subset of cases that are much more mild, potentially even carriers only, that present maybe potentially only with ANSD and some very, very mild symptoms. And I'll use an example of a case I just very recently met in Australia, and he's a 65-year-old gentleman with just recently diagnosed with RTD type 2. But unlike the cases I presented, he has mild hearing loss at 65 years old, but with almost no speech perception. He's still able to walk, but he walks with a cane, and he's only got mild neuropathy. So I think it's important to realize as time goes on, we may find a lot of these much more mild cases, and many people might be treating these right now and not even knowing.
All right. Well, I think that puts us at an hour and a half. So, Carolyn, should we wrap up?
Yes, I don't see any other questions coming in. I just wanted to thank you all. I'm not a pediatric audiologist myself, but RTD wasn't on my radar at all. And I really thank you so much for your time and expertise in putting on this presentation. I think it's going to go a long way to spreading the word to other audiologists around the world. And we're getting a lot of thanks through our Q&A from the attendees today. So thanks, everyone, and thanks to our attendees as well. And we hope to see you back in another Audiology Online course soon. If you're interested in viewing the other courses in our library presented in partnership with Cincinnati Children's, you can use the search by topic, and we've actually listed them all under the topic, obviously pediatrics, but also Cincinnati Children's to make them easier to find. Thanks, everyone. Have a great rest of your day.